Greetings and welcome to the McLaren Health Management Group's presentation on doing what's best in hospice and palliative care. My name is Matt Musey and I'm the Manager of Volunteer Services with McLaren Hospice. And here with me is Chris Hurley, Business Development and Sales. We appreciate you all joining us during this unprecedented time, but hope you are all staying healthy and safe. You may need to bear with us as this is our first time presenting in an online format. McLaren Health Care, or Health Management Group, is a subsidiary of McLaren Healthcare. And within our umbrella, we have home care, palliative care, hospice care, home infusion, long-term care pharmacy, and medical laboratory. As you can see on the mitten, our infusion company covers the entire state of Michigan, which is outlined with the light blue, including the Upper Peninsula. The darker region is the service areas for home care, palliative care, and hospice care. On this slide, this is what we consider the continuum of care, which includes the differences between home care, palliative care, and hospice care. And while many of these items will be covered today, if you would like a handout emailed or mailed out, you can find our information on the last slide.
So, hello. This is Chris here talking now about palliative care. I think one of the biggest misnomers is people wonder, what does palliative care really do? And what does a serious illness really mean? And for us, it's really chronic disease management. So any chronic care diagnosis is someone who would be appropriate for palliation. We focus mainly on the relief of symptoms and the stress of that chronic condition or serious illness, however you would like to look at it. Our goal is to provide quality of life for both the patient and their family, and oftentimes we work very diligently with that family. We're a support system to help patients live as actively as possible until death, and that's part of the WHO organization of 2004. So what is our palliative care program here at McLaren? We have nurse practitioners and social workers that work together with the patient's physicians, whether primary or all their additional specialists such as pulmonology, cardiology, to help provide that extra layer of support. Palliative care is appropriate for any age and at any stage of that serious illness or chronic care. We can provide it right alongside with curative treatment. So for our cancer patients, they're receiving chemo and radiation. We're going to work right alongside those oncology physicians and provide that care for them. What are the benefits? Well, truly, the benefits are relief of symptoms and the stress. We are able to help patients better understand their disease and diagnosis. It's a time where they can ask a lot of questions, help them clarify their treatment goals, and there are many options that are out there. We also help them understand and support the patient's ability to cope. Oftentimes, we're in and out of the hospital and we're having trouble because we don't have the resources that we need. So our team will help with those things. We're going to assist with making those medical decisions. Sometimes it just takes a nurse practitioner or a social worker sitting down with your loved one and really talking about your treatment options. Here at McLaren, we look at home care, palliation, and hospice all as a treatment option, as well as doing nothing if you're looking at making those choices. We're going to be coordinating along with patients, doctors. I like to look at it as this. Our nurse practitioners and our social workers are actually the stem of a flower. The patient is in the center, and all those petals are different people that are involved in that patient's care. Again, it could be oncology, pulmonology, cardiology, primary care physician, maybe it's a primary care nurse practitioner. But again, I like to symbolize us as that stem that holds us up and holds the patient up as they're going through all their treatments. What do we care for? Quite honestly, we have quite a list here for you to review. Obviously, a cancer care diagnosis, someone with advanced COPD or CHF, someone who may have had a stroke, renal disease, which is end-stage renal disease. Again, any cardiac diagnosis that would require help with symptoms. Liver disease, again, ALS, HIV, dementia, Alzheimer's, and many more. And many of these are in combination for some of our patients and families. How do we identify whether they're appropriate for services? One of the things that we really want people to focus in on is, would you be surprised if something would come along and your loved one might pass away in the next year? I look at it with my mom. She's 92 years old, and you know what? Honestly, she could pass at any time, but I want to make sure she's comfortable during all that. So again, complex care. So we're looking at symptoms that we're trying to manage. Potentially metastatic disease, again with cancer, that also may have heart failure, multi-system organ failure, which often happens with many of our patients. Any difficult to control symptom. One of the biggest triggers for palliation is how often they're readmitting to the hospital. Maybe they're not even readmitting, they're only entering into our emergency department for IV therapy or something along those lines. Perhaps they were a past patient of ours under hospice care and they've graduated from the program and now they're seeking medical advancements and medical treatment at this point in time. Those that have a limited social support system. Many of our elderly live alone and live far away from family. And again, just to provide clarity, it's not just for our elders. Patient or family requests related to fetal care, and that there's no history of any advanced care planning, which is something that we definitely encourage all of you today. And we also have a book called Hard Choices for Loving People, which can be supplemented to you as well. So if you wanted to reach out to us at the end of this, it helps you and helps your loved ones make those decisions on what is it that we truly want in our advanced care planning and who do we want to be our medical durable power of attorney. Again, what are some of our goals? Again, the symptoms and the distress that comes along with heart failure, which might be pain, fatigue, dyspnea, those sort of things. So if we look at all these symptoms, these are the things that we really focus on: pain, nausea, vomiting, our fatigue, constipation. When we take a lot of pain medication, constipation kind of follows along with that. Maybe it's diarrhea that follows. Again, malignant or chronic bowel obstructions that often happen when we take a lot of medications or just by disease process. Trouble breathing, shortness of breath, not wanting to eat, and as we get older, oftentimes our appetite does decrease. If we're having trouble sleeping, or we're wakeful all night, or we're sleeping a lot, how is our anxiety as we are dealing with our medical conditions? Depression, are we restless? And again, perhaps even pruritus, which is itching, that goes along with some of our disease processes. Again, goals continued. Helping patients better understand their disease and diagnosis, help clarify the treatment options that are out there and their personal goals with their diagnosis, helping them to understand and support the ability to cope with their illness. We often forget the fact that we're all coping, whether it be patient or family. Coordinating patient care. Again, think back to that flower. That NP is helping coordinate all of those physicians that are taking care of your loved one. And hopefully we're helping to reduce unnecessary emergency room visits and rehospitalizations. Where do we provide care? Quite honestly, we provide care wherever our patients call home, whether we're in a skilled facility, assisted living, in their own home, adult foster care homes, and we do a lot of consults directly at our hospitals. This slide actually kind of gives you a little bit of a differentiator between what hospice and palliative care is. I think that the simplest thing that you can think about is, with palliative care, we're still seeking aggressive treatment. With hospice care, we've decided no longer to be aggressively treated, but yet we are going to be managing your symptoms. And we'll move on to the next slide. The process. Quite honestly, all of our referrals require a physician signature. Our nurse practitioner is going to come out and do her initial consult, and subsequent visits as needed. Everyone's different. We're all different, unique beings, so what is good for one may not be good for another. Oftentimes we may start out with a weekly visit, depending on the symptoms that we're trying to manage, and we could be coming out every month or every couple of months as things progress, but we're always available 24/7. And our palliative care team is collaborating with your primary care physician and our palliative care medical director ongoing. Our palliative care team often also recommends home care for our patients where you may need therapy, PT, OT, an additional nurse to come out and provide hydration or wound care to the things of that nature. So again, they're working side by side with our home care team as well. What you're seeing now is a copy of what our rapid referral form looks like. And quite honestly, we've made it very simple for our physicians and our facilities as long as they give us the rest of the information that we might need. Again, it's very simple. You have a spot for home care, hospice, palliative care, and home infusion. Again, who is it that we're going to be taking care of? And then those additional things that we may need, like a H&P, a med list, things to that nature. Again, we want to be doing what's best. That's our motto here at McLaren. Our palliative care team increases patient and family satisfaction and improves our quality of life. We get a lot of complimentary notes and cards from our patients and their families for the care that they've received. The next thing is actually a quote by Dame Cicely Saunders that is quite poignant at this time. You matter because of who you are. You matter to the last moment of your life, and we will do what we can, not only to help you die peacefully, but to live until you die. Again, Dame Cicely Saunders. We're going to move on and talk a little bit more about what hospice care means and to kind of help you differentiate between those. A couple of the biggest misnomers in hospice care is that people think that hospice is a place that we're going to go to. Quite honestly, hospice is wherever you call home, as I had mentioned earlier. Do we often go to a different setting if that's needed because our caregivers are not able to deal with all that's going on with our loved ones? Absolutely. But at the end of the day, it's not a place that we go off to. Back many years ago when hospice was more of a voluntary thing before it ever became an actual program, people were often taken to places, but that is really truly not what hospice is at this point in time. It's a very specialized type of care for those facing a very life-limiting illness for their families and their caregivers. Hospice care is going to address both physical, emotional, and social needs as well as spiritual needs throughout their course of care with us. Hospice care, our team of experts are going to manage those symptoms and they're going to be along the road with you as you travel this journey. Hospice care believes that the quality of life be as important as the length of life. And again, that's also with the National Hospice and Palliative Care Organization. Benefits of hospice. Well, number one, you stay home and you don't have to go back to the hospital unless you so choose. It's for the relief of pain and symptoms and additional stresses brought on by our diagnosis. It helps our patients and their families truly understand what's to come, more about what their disease is all about, and helping them to understand how to cope with that illness as we change. We're going to assist with making medical decisions, the goals of care, which is discussed every time we come out and see you, and we're going to assist a patient to meet their life goals, whatever that may be. Who do we care for? Very similarly to our palliative care, it's any diagnosis that we consider end stage at this point in time. So your CHF, your COPD, your cancer patients, your heart disease patients, lung, ALS, and dementia. How do we identify our patients? Well, one of the biggest things that we look at is, would we expect this patient to potentially be with us in 6 months or less? They're no longer seeking curative treatment, and they have a hospice eligible diagnosis. So each one of these diagnoses that we've mentioned up to this point, COPD, CHF, they all have qualifiers that our nursing team looks at. Oftentimes we look at a multitude of diagnoses and we look to see which of those would our patient fit into the best for hospice qualifiers. Our goals of the hospice nurses, social workers, physicians, our home health aides, spiritual care counselors, and volunteers are that we work together as a team to identify what your needs are. We're going to provide that relief of pain, symptom, and stress of our life-limiting illness. We're going to provide comfort and support, and we're going to provide dignity and independence. Oftentimes we are part of those last wishes, like perhaps you wanted to go out on a fishing trip that you haven't been able to do. We've done things where we've sent people to Disney World. We've also helped patients who their goal was they wanted to be a producer in Hollywood, and we've actually helped with that trip. Hospice does a lot more than what people think of because we're so afraid of that word. Where do we provide care? Anywhere a patient calls home. Again, just like in palliative care, your own home, an assisted living, adult foster care, skilled facility, and we do often do a lot of hospice in our hospitals as well. So this kind of gives you a picture of what our team is all about. In the center is you, the patient and family. We have a medical director that oversees all of our team. We have registered nurses, hospice CNAs, which are certified nurses aides, social workers, spiritual care, volunteers. Additionally, we have therapists, music therapists, bereavement coordinators, LPNs, whoever it takes to come and help you take care of your loved one. Choosing to elect hospice care is an important decision that can improve quality of life for a patient with a life-limiting illness, in addition to providing support to the patient, family, and caregiver during a very difficult time. Hospice care is one of those things it's a very beautiful thing if we are willing to embrace it. Hospice, I look at that word, it's a very scary word, and when we have talks such as this, and if we'd have been there with you personally, the first thing I would have asked you is, what do you think of when you hear the word hospice? And I might have heard someone say death. I might have heard someone say morphine. I might have heard someone say we die tomorrow when we come on hospice care and you take away all of our medication. So I'm hoping that by the end of this you'll feel much more comfortable with understanding what hospice is. And I want you to look at that word one more time before we close. And it's HOSPICE. I want you to take out 3 letters, S, I, and C. There's no K, it's silent in this world of hospice for me. And you're left with 4 letters, HOPE. I look at this program, and a lot of us here at McLaren, as the program of hope. The hope for pain and symptom management, the hope to have those conversations that maybe you haven't had along your trail, and the ability and the hope that you're going to write your final chapter just as all those that came before it. With that being said, what can we do to help you more? And I'm going to turn it over now to Matt to talk a little bit more about our volunteer program.
Thank you. Our volunteer program is really designed to meet our patients' and families' needs. And in our volunteer orientation, I asked the question, what is comfort? Because really comfort for me might be different than it is for you. And so it's about looking at everyone's comfort and what that question means. And so these are a few ideas in which we can meet those needs, and that's by providing companionship visits in many of the facilities or in homes where those individuals live. One of the biggest things that we look at within hospice care is providing what we call respite or short-term visits for our caregivers, especially when we look at caregiver burnout. Many times, especially times like today, we're running errands for the caregivers. We're making sure that they have groceries or the items that they need to stay at home. We have volunteers that may not necessarily want to visit firsthand, but definitely want to help our staff out, and so they assist in the office. In the Port Huron area, we're fortunate enough to have Hops for Hospice, which this year, if everything goes well, we're planning on having that event on Friday, November 6th at Warwater Brewery. And that is, again, just to let people know about what hospice care is in a different way. And it's, again, we look at the opportunity to live life and celebrate life, and while also educating ourselves. Many of our volunteers may play music, whether it be on their phone or maybe they sing, play guitar. They'll go around into facilities or homes and help with that, which is slightly different than our music therapists. We also have volunteers who like to sew. And again, like today, many of them have made masks for our staff. When we're not going through a pandemic, many of our volunteers make fidget blankets, they quilt or sew Afghans, and they also focus in on our bereavement bears, which is allowing someone to give us their loved one's clothing, and we turn that into either a pillow or a bear so that they can remember them by. And of course, there's much, much more in which volunteers can assist with. If you have any questions in regards to today's presentation, this is our information. Chris Hurley's information is on the top and mine is on the bottom.
We would encourage you to reach out to us, and if we can ever be a part of this again in person, we'd love to do that. I think one little added thing with Matt and his volunteer program, they have an awesome group of pet volunteers. And you know, pets, we all know how on bad days they make you feel better, and I think it's nice to know for all of you that it's an all-inclusive program and that we have all these additional things as well. Again, we thank you for allowing us to be a part of your day, and please reach out if there's anything else that we can do to help. Great day.
Thank you.